So we're on track to start at 6:10. Welcome to all of you who have logged in today. It's quite nice and sunny weather, I was saying before, where I am in London. Our two other speakers are in Qatar. I'm sure it's even hotter. I shall ask them in a minute. Dr. Amy is in. Amy, where are you? I forgot. Tell me where you are. I completely forgot.
I'm in Leicester.
You're in Leicester. Of course you're in Leicester. We were saying how there was a Leicester connection here this evening. And there will also be a Chesson connection. One of our speakers here is quite a popular Chesson. So far, looking at the list, I can see a lot more lessons than we've had. Is he also a Chesson? Really? On mute. Tell us more. Tell us more.
Yeah, both Chessons, absolutely.
Both Chesson and I'm a lesson. Enough said. Yes. So I've seen a lot more lessons on here than we've had. Is that not right, Anna? I've been looking at the list there. So
that's very true. I don't know if they're the Chessons attracting them.
Yes. So it's lovely day today. So really thanks for thanks to our speakers for being here today, and also for you all coming here today to listen to us. So we'll be starting in about a minute. It's 6:09, and we will start with a survey that we did. Anna, if you can just share that now. So our webinars are called CamDocUK, Talking with the Community, and we always want to make sure that the topics that we're talking about is actually what you want to listen to. And this time, as we wanted to do women's health, and there's just so many topics in women's health, we sent out a survey to our groups. Thank you to all of you who responded. We got 40 responses. And the topics that we chose today were the two topics that came top. So you can see there, COVID-19 and women's health was one of the popular ones, and fibroids. So this is what we're talking about today. But if we scroll down, we can see that there was other things about fertility in the COVID area, carriers and later fertility, higher mortality and morbidity amongst Black women, screening recommendations. So lots of other things, which obviously we have experts in the field who would be happy to come back and talk about it at a later stage. Thank you, Anna. So, good evening. It's a pleasure to see you all here today. This is now our 11th webinar in the series CamDocUK, Talking with the Community. So, as I said, we asked you what you wanted to have discussed, and the two topics that we're discussing is what we're going to be discussing. I wasn't surprised to see those two were at the top of the pile. Obviously, we're in the middle of a pandemic, which doesn't seem to be abating. So it seems that COVID-19 is going to be here with us for a while. So things like being pregnant, you're more likely now to be pregnant in the middle of a pandemic. So I wasn't surprised that you wanted to hear about that. And of course, fibroids, they're very, very common, and 1 in 3 women develop them. So we have three very excellent speakers today. Our first speaker, who is Miss Amy Ivare, will be talking about fibroids, and she's entitled her talk, Fibroids, the Unwanted Friends. And I think by the end of her talk, you really know that they are really unwanted friends in terms of all the symptoms and things that they cause. So I'll tell you a bit more about Amy. You heard me asking her, I completely forgot that she was in Leicester, but Amy's Cameroonian, and she's also Ugandan in heritage, and she's currently working for Leicester University Hospitals. She qualified in 2010 from the Universities of Hull and York. She has a subspecialty interest in urogynecology. I'll ask her to explain that when she starts. And she's fascinated by factors that affect health-seeking behavior, clinical outcomes, and research in the above specialties. She is a CamDocUK member. She recently joined, and it's testament to how keen and eager she is that when we asked her to speak today, she didn't hesitate. So thank you, Amy. The floor is yours.
Thank you very much for that introduction. So urogynecology is basically all about the female pelvic floor, so the bit that holds everything in the lower tummy up. And it changes a lot, especially for women who've been through childbirth and pregnancies, and those changes interest me and how we manage those. Anyway, coming back to today, I'm going to kick off with a short talk on fibroids. It's by no means everything about fibroids, but it should be a good summary to start from. I'm quite happy to take questions afterwards. So we start off looking at the plan for today, just talk about what fibroids are, and just talk through as well what kind of symptoms you might get, how you might know that you have them, and the things that we might do to diagnose them or to find out if the fibroids are what's causing the problems, and the common ways in which we can manage them. So we use lots of fancy names to call them, but fibroids are basically extra growths from the muscle of the womb. They're not cancerous, and they don't in themselves, kill people, or but they can cause other problems. They're very, very common, and at least 1 in 3 women will have them. We don't know exactly why they happen, but we know that their growth is fed by the female hormone estrogen. And we know this because they're very common between the ages of 30 and 50, which is when you have all the female hormones around. After the menopause or the change, they tend to shrink or go away. They also tend to be more common in women of Afro-Caribbean heritage or Black women. We're not sure exactly why, but there might just be a difference in our tissue structure. So this is just a picture to remind us of what the normal female organs would look like. So if you look down here, there's a picture of the lower half of a woman's tummy, and the normal female organs would usually sit down here. So you would have the vagina leading up to the cervix, which is the neck of the womb, and that's usually then connected to the body of the womb. You have the tubes going off at the top here on either side, and then you have the ovaries attached here. If you notice, there's a space in the middle of the womb, and that's usually where a baby would grow from, and it's also where your periods would come from. Now, fibroids are very variable. Every woman has completely different fibroids. They may have, just one really big one or several really big ones like here. They may have them in different parts of the womb, or some women just have lots of tiny ones all over the body of the womb. Now, what things might tell you that you may have fibroids? Now, for every woman, like I said, it's completely different. And the signs or symptoms that you might get will really depend on where the fibroids are, how big they are, and what they're attached to that's causing the problems. Most women have no problems whatsoever, no symptoms. The commonest problem that women might come with is bleeding problems. So fibroids can cause very heavy period bleeding. They can cause periods that last for much longer than you would normally get them. So rather than having a 3 or 5 day period. Some people bleed for a week or even 2 weeks sometimes. They can cause periods that sort of stop and start and never quite have timing to them, or get triggered by random things like going for a run, for example. If you have particularly large fibroids resting on different parts of your tummy, then you may present with other symptoms like pain, whether it's pain in the tummy or pain in the back, pressure on the bladder causing you to need the toilet a lot, or pressure on the bowel or the back passage. That has the opposite effect, so you struggle to open your bowels. When you go to see your doctor, they might do different things to try and figure out if your symptoms or your problems are being caused by fibroids. We'd normally examine you first. Examination usually entails having a look in the vagina with a little instrument, and then having a feel. So we normally have fingers of one hand in the vagina and fingers of the other hand on your tummy to try and feel the womb and feel if there are any lumps that shouldn't be there. You may also then go on to have an ultrasound scan or a jelly scan, which is where we use an instrument with probes like this, put some gel on it, pressure on the tummy, and we get a black and white picture that we can interpret to tell us what's going on in there. You may also need a scan where we put a little instrument, probably as wide as your thumb, into the vagina to have a look. And again, that gives us images that we can look at to try and figure out what's going on in there. Some people need something called an MRI scan, which is again just another way of looking at the insides. It's basically a large donut type thing that you get fed into. And again, it gives us these black and white pictures, and we can see very nicely what's going on in there. Some women, especially those who have fibroids that grow in the space inside the womb, might need something called a hysteroscopy, which is where we put a small camera through the vagina into the neck of the womb and the womb to have a look in there. And this is just a picture trying to demonstrate that. So fibroids can cause different kinds of problems. Thankfully, most women have no problems whatsoever, and that's fine. You don't necessarily have to do anything about them if they're not causing you any trouble. And we find this a lot when we do things like scans or examine women for different things, and then we find fibroids. If they're small or normal sized fibroids and you're not bothered by them, they don't necessarily need treating. For some women, they can have really problematic bleeding that can affect their life, can affect their work, can affect their family life, relationships, and can be quite expensive, especially for women who have to buy sanitary towels or products all the time because they don't know when they're going to stop bleeding, or they're bleeding just so heavily that they can't be sure that they won't have accidents. And other women bleed so heavily that their blood count drops, and they need that to be replaced, whether it's with iron tablets or blood transfusions. Now, this is a picture, again, just to try and show you how the female organ sits in the lower part of the tummy, but this is sideways. So if you, that woman that we had at the beginning, if you sort of cut her in half and turned it to the side, this is what you'd find. So lower part of the tummy, there's a little bone right down there, and just behind it is the bladder, just behind that is the womb and the vagina, and just behind that is the bowel. Behind that is the lower part of the spine. So you can imagine if you had a really big fibroid sitting just here, that will cause a lot of pressure on the bladder. And unfortunately, that means you have to go to the toilet quite a lot. So your bladder cannot fill up as nicely as it would like to. So you don't have that time really to wait to be able to go to the toilet. If you had a large fibroid sitting back here, then that could cause a lot of pressure on the bowel or the back passage. And that means then that any stool or poo or feces coming down struggles to get out through this exit. So you might suffer with constipation. If you have constant pressure pushing down here, then you may well get back pain. And if you had a rather large fibroid sitting here, then you can imagine that you'd have constant heavy pressure and even pain. And again, this can cause really troublesome problems with family life, work life, and people who are in pain all the time might struggle to work normally, might affect their self-confidence, mental health. Now, fibroids can also cause problems with fertility or people trying to get pregnant. This is a diagram to just remind us what we need to be able to grow a baby. So the ovary here would normally release an egg that travels up the tube, and the sperm would come up through the vagina, through the womb, and meet the egg somewhere here in the tube. It would then fertilize that egg, and the newly fertilized egg would travel back down to that space in the body of the womb and find a healthy spot to grow its roots. And from that, you grow a baby. So you can imagine if you had something like this, where you have all these fibroids or lumps in the way, so especially this here and this here, would make the entry point of the sperm and the exit point of the egg really difficult. It would also mean that that newly fertilized egg would find it difficult trying to find a healthy spot in the womb here to put down its roots and to grow into a baby. So that's where the problems with fertility come from in general. During pregnancy, thankfully, once people are pregnant, most women will go through pregnancy without any problems because they have fibroids. Sometimes, if the fibroids grow a lot, they can start bleeding inside or start dying inside a little bit, and that can cause a lot of pain. Also, you can imagine if you've got this womb that's already growing and taking up space, and then you've got this lump on top of it as well, it might increase the symptoms of pregnancy, especially those around pressure symptoms. So whether it's back pain, pain in your hips, having to go to the toilet all the time, or constipation. Now, unfortunately, sometimes when women get pregnant and they've got rather large fibroids, especially inside that space in the womb where the baby should be growing and expanding, it might limit the amount of space or healthy space that that baby has to grow. And it may mean that the pregnancy is more likely to end in miscarriages. So the pregnancy might be lost. It might also mean that the baby gets born early because the space in the womb is limited. The woman can go into labor early and the baby can be born too premature. If you have fibroids in the right place in the womb, it can also cause problems later on in pregnancy. Now, when women are pregnant and they get into the end of pregnancy, the babies usually come or turn head down so that they can go through labor, go through the neck of the womb and the vagina to be born. If you have fibroids sort of blocking that process, then the babies can find themselves in any position really. So they can lie across the womb, which means that they cannot get out, or they can lie with their bottoms down, which can get out in some instances, but some babies that lie like that might also need a cesarean section. If you have fibroids that are obstructing the exit from the womb, then even babies that are coming head down, like or bottom down, may not be able to come out at all, like in this picture, and would need a cesarean section as well. Usually, once women have had their babies during labor, the womb is very clever. It's expanded so far, but it's got these mechanisms in place where it can clamp down on itself. This large balloon, it can just collapse and stop all the blood vessels that have been feeding baby from continuing to bleed, so that the woman doesn't lose too much blood. However, if you've got all these little lumps in the way, then that process might not work so well, and you might end up losing a lot more blood than you should. So those are the potential problems, and we're just going to talk quickly on ways in which we can manage them. So management, again, really depends on what problems you're having, what type of fibroids you have, and what outcome you want. So you really need to decide for yourself if you can manage them at home, and most women can manage them just fine. And most women can either change their lifestyle or make changes at work, or do things on a daily basis that make them feel more comfortable. Some people need to take painkillers if they're in pain with the fibroids, or they're in pain with the periods. Some people take tablets to try and reduce the amount of bleeding that they have. Some people need tablets with hormones in them, usually contraceptive type pills or injections or implants or the coil. And sometimes doctors, or we can give medication to help shrink or reduce the fibroid. And sometimes we can do operations to reduce or take away fibroids. And if there are complications like low blood count, then we can talk about treatment options for those. So sometimes we do operations for fibroids, and I'll just talk through some of them very quickly. This picture here is something called uterine artery embolization. And what we do here is inject into one of the blood vessels in the top of the leg some substances that reduce the blood flow that's going to the womb and the fibroid, and the aim is to shrink them. This next picture is something called endometrial ablation. This is just one type, and what it aims to do is to destroy the lining of the womb in that space inside the womb where the period blood comes from, so that we reduce the amount of bleeding that women have. It really only works well for women who've got really small fibroids inside the body of the womb or the lining of the womb. These two are not so good for women who are planning to get pregnant. The next one is called resection, which is where we do that camera into the womb. And while we're there, we can shave off or take off those fibroids that sort of grow into that cavity in the womb. We can also do something called a myomectomy, which is a tummy operation. And we make a cut in the womb, take out the fibroids, and then close it back up again. And finally, the cure or the treatment really for fibroids is to take the womb away, because this is where the fibroids are going to grow from. And it will also prevent any future fibroids growing there again. So if we talk about specific management for different problems, if bleeding is particularly problematic, then like I said, there are things like taking painkillers to manage pain. Things like diet and exercise might help as well with bleeding, blood loss, and feeling better during periods. Some people find having a warm bath or warm showers, drinking warm drinks, or herbal teas like clary sage, chamomile, or mint makes them feel better. Excuse me. Taking vitamins like vitamin C especially helps the intestines to absorb iron from the diet, and increasing foods that have iron in them, like green vegetables, beans, those kind of things can also help with blood loss. Some women need iron supplements, some women need prescribed iron tablets or iron injections, and some women, if the bleeding is really heavy, might need blood to be given back to them, so blood transfusions. Reducing the bleeding, the commonest things we use are really hormones. So whether it's hormone tablets, like contraceptive tablets, or injections or implants, or this coil, that's an example of one is basically a plastic device with some hormone in it, sits in the womb like that and just works locally to reduce the amount of bleeding. With women who have pressure problems, especially with large fibroids, it's the case of managing toileting habits, maybe using things like laxatives or suppositories into the bottom to try and help constipation. But really, the way to manage that is to take away the fibroid or to take away the womb. With fertility problems, if people are struggling to get pregnant, then we normally look at, especially if they had large fibroids growing inside the cavity in the womb, is to take those away, really. Some women might need assisted reproduction, so IVF, and for some women who still struggle after that, then it's really things like surrogacy, so getting someone else to carry the baby for you, or adoption. In pregnancy, most of the time, thankfully, women don't have such serious problems, and even when they do, they can usually manage by changing things at home or by getting someone to help. We very, very rarely do operations for fibroids in pregnancy because it increases the risk of bleeding, losing the pregnancy, and even losing the womb. So we try to avoid them in pregnancy if we can. For women who are struggling with miscarriages, we can look at removing those fibroids that are inside the womb, especially before they get pregnant next time. For babies who are not coming in the right position or fibroids are blocking baby's exit, then we can do things like cesarean sections. Like I said, some babies can be born bottom down. And usually, most women with fibroids, their body still knows what to do, it still clamps down quite nicely after the baby is born and they don't bleed. But we're always aware of women who are at higher risk of bleeding, and we usually have a management plan during the pregnancy to reduce the risk of that happening afterwards. Thank you.
That was excellent, Amy. I literally just wonderful. Obviously, as a GP, I see a lot of this, and that was a really, really helpful refresher course for myself as well. I'm sure the audience found it really, really exciting and very, very helpful. If you could please stop sharing your screen. So I already have a question for you, and this came in quite early on. It says, hello, our fantastic doctors. I'm African. It's from an anonymous attendee. I really wish you can tell us your name at the end. I have been depending on blood transfusions for over 5 years due to heavy bleeding. As of 2019, my womb showed that I have 20 fibroids, and the biggest is 9.5 centimeters. I was advised to let them remove the uterus. They said they cannot recommend me to have a baby. I am in my 40s and I would like to have a child. They said my womb has been stretched. What advice would you recommend?
Right, first of all, I'm really sorry to hear that. It sounds like you've had quite a hard time. Unfortunately, fibroids can cause difficult situations like this, especially when you've got problems that are causing medical issues like low blood count, needing blood to be given back to you all the time. But at the same time, when we have wishes, especially like having children, that can be really difficult when it comes to managing these fibroids.
Yeah.
Like I said, there are lots of different ways of managing them. Most of the time, the options for managing bleeding, especially, which sounds like that's the main problem you're having, would be some kind of hormonal control, which unfortunately would affect your ability to have a baby. Failing that, like I said, there are options to do operations to remove the fibroids. Now, I don't know where your fibroids are, and I don't know all of your medical history, so it's hard for me to advise you on, exactly what to do. But there are options of having the fibroids removed or reduced in size. The definitive management, I suspect, where your doctors are coming from is maybe looking at the fact that you're needing blood all the time and that your life is probably threatened every time your blood count's too low. It's to have it all removed so you don't grow any more fibroids. But of course, that makes it difficult. I wonder if you thought about other ways of having children, like I mentioned, maybe assisted reproduction. Things like that might be something to have a discussion with your doctor about.
Yeah, and I think there's a follow-up to that question from the same person. She said she forgot some information as part of her question. She's anemic and she has a low platelet issue, so she's got ITP. And another hospital have told her they can remove her womb, but the gynecologist who has been treating her for 19 years said it's a risk going for an operation. With my condition, they've recommended abduction on medical grounds. So
yeah, that sounds really hard, really hard. I'm sorry. Yeah, I think with the recommendation of an operation, I can understand why you're a bit worried with the history. Maybe have you had a chat with your hematologist or a blood doctor? You should have one of those if you've got ITP long-term, they may be able to advise on the risk of bleeding, and they may be able to work with your gynecologist. There's also anaesthetists who look after you when you're asleep during operations. I think you need one of those as well. And if they can all work together, they might be able to come up with a safe plan for you.
Yeah, totally agree there, Dr. Amy. And failing that, if you're not able to speak to the specialist, I doubt you won't be able to, but your GP can be the middle person and be your advocate. Obviously, I'm a GP, so I'll always say that we're
absolutely,
help.
absolutely.
So
absolutely.
yeah, if you're not sure and you're getting all this information left, right, and center, come and speak to your GP. They'll be very happy to help. And again, as Dr. Amy said, I'm really sorry to hear of your troubles, and we hope that you get to a good outcome with that. Yeah, so a really good question to get us going there. There's another question for you, Dr. Amy. Do you think that diet can keep fibroids under control?
So unfortunately, I don't think there's any evidence at the moment that particular diets or particular foods prevent fibroids as such. Like I said, there are some studies that have been done that show that some herbal supplements, especially things like clary sage or raspberry leaf tea, might help with the bleeding and the pain that comes with fibroids, but not actually preventing or treating the fibroid.
And if I were to go back to what you mentioned at the start of the talk, you mentioned that fibroids are quite common in Black women, and certainly in practice that's quite reproducible. You mentioned we don't really know why. I was reading the other day that perhaps it's got to do with the fact that perhaps we tend to be a bit more overweight. What are your thoughts on that? And how would that work?
So I'm not sure of the exact numbers or the exact risks that being overweight exposes you to as far as fibroids are concerned, but certainly being more overweight increases the amount of that female hormone called estrogen. So if you imagine that the fibroids are being fed by this estrogen being around, then you could see why you're more likely to get the fibroids. Having said that, we do also see fibroids in normal weight and thinner women. So don't automatically think that because you have fibroids because you've got too much hormone or because you're overweight, because we also don't see them in women who are overweight.
That's very helpful. And just one last question. We'll come to you at the end again when we do a general roundup. So obviously fibroids can affect fertility. Would you then always recommend that, if someone has got fibroids, that a woman has got fibroids, she's of childbearing age, there's a few of them already that she already then considers about trying to get them removed before, is that a conversation to have early on then? Obviously, in some cases, the patients present very late to us. So perhaps, unfortunately, if our first, the first question we had, perhaps if it was picked up when she had maybe 5, and they might have been able to do something. So would you recommend that it's something that you have a conversation early on with your doctor?
So I would always recommend having conversations with your doctor, is the first thing to say. As far as fibroids and fertility are concerned, unfortunately, it's never a straightforward picture. So it's very variable, and it really depends on what sort you have, whereabouts in the womb they are, how big they are. And also fertility depends on lots of other things, not just the structure of the womb. So I think if, for example, you've got fibroids, someone scanned you and you've got, 3 or 4 centimeter fibroids, but you've managed to get pregnant before, and you've had your babies without any problems, then I wouldn't really focus too much on the fibroids. I would go ahead and carry on if that's what you want to do, have your children. and then talk about them if they're bothersome. Because some of the management options, like I said before, for fibroids can affect the ability to have children. If, however, for example, you're a 20-year-old and you've got this massive fibroid sitting there that you can see, you can feel it's there all the time, and you're worried that it may cause problems, or you're thinking about having a baby in a couple of years' time, definitely talk to your doctor about ways of managing that before you start off. Or if, for example, you're a 35-year-old who's never gotten pregnant, never used contraception, then definitely talk to your doctor, because it might be the fibroids, but there may also be other reasons why you're not getting pregnant.
Thank you so much, Dr. Amy. It's been really, really fascinating. Obviously, we could keep talking and asking you questions, but we have two other fantastic speakers, and we shall move to our next topic, which is about COVID-19 and women's health. And it's my absolute pleasure to present this next speaker, who is none other than Professor Justin Konje. Prof was born in Bamenda, and he studied medicine in the University of Ibadan. He started his postgraduate training in Ibadan and completed it in the United Kingdom. He was appointed a consultant and senior lecturer at the University Hospitals of Leicester NHS Trust and the University of Leicester in 1998. And he became a professor of obstetrics and gynecology in 2004. In 2014, he left the UK for a sabbatical, and he retired from Leicester in 2016. And now he is an emeritus professor at the University of Leicester, but he's currently based in Qatar. He is one of the founding members of CamDocUK and our one but previous last chairperson. So I'm really, really excited to hear him talk today. And of course, as I mentioned in the intro, he's a Shesan, a proud Shesan as well. Over to you, Prof.
Okay. No, that's okay. We're not ready yet. Yeah, that one. Yeah, okay. Okay, can you see me? Yeah. Linda?
Yes, I can see you, Prof.
Great, okay. So good evening, everybody, and thank you very much, Linda, for the introduction. And I'd like to thank CamDoc. I'm what you probably call the grandfather of the organization, and it's a real joy for me to see how the organization has evolved. Amy's presentation was very good, and like somebody who prouds himself as an expert in fibroids, I was sitting here and just shaking my head and thinking, well done, well done. So I'm supposed to be here not to be a bit on the side, actually, because Osric and Amy are supposed to be leading the show. The topic that I'm supposed to be talking on, which is really introducing what Dr. Navti will talk about, is about COVID and reproductive health, or COVID and women's health. I've just had a look at the people that have logged on to this seminar, and there are doctors and there are non-doctors. And actually, somebody who is my senior and very close to my heart is actually listening. So I'm very, very pleased and humbled that Dr. Jaiyesimi, Professor Jaiyesimi, is actually one of the people that is on this seminar. So well done, CamDoc. But what I'm going to try and do is introduce COVID in general, speak about aspects of COVID and women's health, and there will be a slight overlap with what Osric will talk about, because he's going to focus mainly on pregnancy. So what is COVID? Well, I'm hoping to cover a bit about the virus itself, and I promise I'm not going to bombazle anybody who is not a medic with lots and lots of medical things. How is the virus acquired? Just to remind us what we know already, because everybody should know about this pandemic. What are the symptoms? I'll look at how the virus may affect male and female reproduction, because those are things that we don't talk a lot about. And I'll touch on vaccination, again, something that I think Osric will touch on again, and what vaccination means in terms of reproduction and in terms of pregnancies. This is the virus, which is, that causes COVID-19. The name of the virus is derived from the fact that it has these spikes that make it look like a crown when you wear it. The virus, when it enters the body, it has to attach itself to something we call receptors. And where it attaches itself determines what happens to the body. And these receptors are located, we find them in the nose, down the windpipe, in the lungs. They are found in the heart. They are found in the kidneys. They are found in the womb. They are found in the ovaries, in the vagina, in the testes. It's important to understand where these things are, because the way that it affects the body depends on where the virus attaches itself. It causes COVID-19. So COVID-19 is a disease, but that disease is caused by the virus. The virus is called SARS-CoV-2. And I'm not going to go into details as to what the SARS-CoV-2 really stands for. We know that this virus comes from animals. We believe that the main source of the virus are bats, but in this family are also what we have in the Middle East here, camels. So the Middle East respiratory virus belongs to the same family. So these viruses go from bats and then to humans, where they cause the problems. This is just to remind us that this virus was first identified in December 2019, and you can see that it spread very, very quickly, that by March 2020, it had been declared a pandemic. A pandemic is a disease that affects most parts of the world. That was how fast it spread. And as of today, there are over 177 million confirmed cases worldwide and 3.8 million confirmed deaths as of today. And I believe this is a very, very underestimation of the magnitude of this problem, because there are many parts of the world where the cases are not being identified properly and they are not being passed on to WHO. So how do we get this virus? It passes from person to person. And the virus is present in little droplets. So when you cough, you sneeze, you laugh, you speak, you sing, you spread the virus out. And these droplets will stay in the air for a little while and then fall down. And so if somebody's close to you, a meter apart, that person can actually get these droplets and get an infection. The droplets have to attach themselves to what we call a mucous membrane, so it could be the eyes or the mouth, and then they go on to the airway where they attach themselves to those receptors and then start causing problems. What are the symptoms? That is, when you have the virus, what may you demonstrate? What may you have to make people suspect that you may have the virus? Well, the good thing is that most people who have the virus have no symptoms. It is good, but it's also bad. Bad in the sense that somebody has the virus, they have no symptoms, and then they may be able to spread it easily. So we know that in pregnancy, 3/4 of the women who have the virus have no symptoms. But the most common symptoms will include headaches, dry cough, muscle aches and joint pains, fever, sore throat, shortness of breath, shivering, your nose is congested and leaking, and loss of smell, you cannot taste at all, you feel very tired. Then there are other uncommon symptoms like chest pain, pain in the tummy, diarrhea, nausea, and vomiting. We know that there are certain groups of people that are more likely to have the disease that is very severe. The Black and ethnic minorities are more likely to have severe disease, 4.5 times more likely to have severe disease. The older people are almost 2 times more likely to have severe disease. If you're obese, so your body mass index is over 30, so you're weighing, just depends on your height, then again, the risk is much greater. The same with diabetes, you have high blood pressure. So these are some of the factors that if you have, and you have the disease, you're more likely to have a severe disease. But why is it that the ethnic minorities, so for example, in the United States, in the UK, there are many more Blacks and Asians who have died from COVID than other ethnic groups? Well, there are suggestions on why this might be the case. One is that if we take the living conditions, these people who are from minority groups like ourselves are more likely to be living in poorer environments. There are maybe more people living in the same household, and therefore the spread is faster. Occupational exposure, many more ethnic minorities are working in care homes. They are working as nurses. They're working in other places where they are more likely to be exposed to the virus. And then things like diabetes, high blood pressure, and being overweight are also more common in minorities. So those are some of the reasons that we believe makes people from ethnic minorities more likely not only to have the disease, but to have very severe disease. So I'm going to move and just focus on the next few slides on reproduction. Does this virus have an effect on male reproduction? At the beginning, I said, what allows the virus to attach itself to different parts of the body, the receptors are found in the testes. We know that men who have the virus and they're very sick, they have what we call otitis, which is an inflammation of the testes. The testes get swollen, they're painful, and they're very red. They've also looked at the sperms from these people, and the quality of the sperms has been reduced. What is unknown is whether that reduction is short-lasting or long-lasting. There are some data coming out from Europe, and especially Italy, saying that men who have had very severe illness struggle to have children much later, because it looks as if this virus actually affects the way the testes produces sperms in the long term. What of women? Does it affect female reproduction? There is some evidence coming out now to say that it does affect the ovulation, because we have the receptors in the ovaries. If the woman has very severe disease, then that severe disease can affect the ovaries. But if she becomes pregnant, because the receptors are also present in the uterus, she may have a miscarriage. But the data about miscarriage is not very, very strong. Those that have the disease and they're very sick and they're pregnant, they may have a miscarriage. And there's a possibility that because of all this, the women may in fact struggle to become pregnant. So the recommendation nowadays is that if somebody has got COVID and is going to be investigated for infertility, they should delay treating because of the potential consequences of the COVID on fertility. My last slide, I hope, is, can COVID be transmitted sexually? There are certain viruses that can be transmitted sexually that can go on to affect the pregnancy. There isn't very strong evidence now to say that COVID can be transmitted sexually, but the virus itself has been isolated from the sperms of men who have had infection. And this isolation has actually been up to 1 month after the infection. But beyond that, they haven't found the virus in sperms. So it is highly unlikely that COVID can be transmitted sexually. However, because COVID is found in saliva, there is some speculation that it can be transmitted through oral sex. Now that hasn't been confirmed yet, but there is evidence some evidence saying it's possible. So if I just perhaps spend a few minutes, 2 minutes on vaccination, just to say that there are 2 types of vaccines. And you have to excuse me for using medical terminology here. One of them is the mRNA vaccine. So the vaccine doesn't have any viruses itself, but it has some components of the virus. It helps the body to develop antibodies to fight the virus. The other type of the other type of vaccine has viruses called the adenovirus. Now, we know from studies in the United States where they've looked at over 30,000 pregnant women who have been vaccinated that the vaccine does not cause any problems in pregnancy as a whole. However, the vaccine that contains the virus, the adenovirus vaccine, we know that it causes a slight increase in blood clots in younger people, i.e. the younger people likely to be women. And we know that pregnancy itself increases the risk of blood clot by 5 to 6 times. And so there's a combined pill. So when you add on top of that COVID, it increases the risk of blood clots. The implication of this slide is that if we look at the risk of COVID, the risk of pregnancy itself, and the risk of the combined pill, if you compare those risks to the risk of blood clots with the vaccines, the risks are very, very small. So the advice is that if a woman is planning to become pregnant, she can have the COVID vaccine, but it should be the mRNA vaccine. If you're pregnant and you're very worried about COVID, the mRNA vaccine is safe at the moment, but not the adenovirus. So I will stop there and I'll ask my colleague to complete the session on COVID and reproductive health before we can take questions, I think.
And if I can just introduce Dr. Nafti before he starts his talk. Dr. Osric, he's a fellow of the Royal College of Obstetrics and Gynecologists. He's trained, we call it a subspecialty in maternal and fetal medicine. He qualified from the College of Medicine in the University of Lagos, and then he completed his postgraduate training at the University Hospital of Leicester, where he was consultant before moving to Qatar 4 years ago, which is why you can see him and Prof in the same room. Currently, he's a senior consultant in maternal fetal medicine at the Hamad Medical Corporation, and he's an assistant professor of clinical obstetrics and gynecology at Weill Cornell Medicine in Qatar. He's also one of the founding members of CamDocUK, and he served as the first secretary. And I have to add as well that he's another proud Chesan. So over to you, Dr. Nafti, to complete the presentation.
Thank you, Linda, and thank you everyone who's taken the time to join us this evening. I'm delighted to see lots and lots of names that I recognize. So hopefully over the next 15 minutes or so, we will go through COVID-19 and its implications with regards to pregnancy. There will be some overlap with what Prof said, but overlap is good for emphasis. So what are we going to talk about? Okay, so this is really what we're going to try and do in the next few minutes or so. So what if I'm thinking of getting pregnant? What you would need to do once you got pregnant? How does COVID impact pregnancy, and how does pregnancy impact COVID? What measures can you take to reduce the risk of getting the infection? What you should be aware of? How does this impact your delivery? Is breastfeeding okay? And also then a bit about vaccination, again, to emphasize some of the points that Prof has already raised. Now, Prof has highlighted this. The reason why we focus on this is essentially because our populations are at higher risk of being admitted to hospital with COVID-19 and also of getting more severe disease. So it is important, if anyone is feeling unwell or has any specific concerns, not to ignore them, because there's clearly a concern about going into hospital in the days of COVID because people are worried about getting the infection. But of course, that can mean delays in getting the appropriate treatment with tragic consequences, as you can imagine. Now, when we talk about planning a pregnancy, it's a very, very personal decision, and it's all based on the dynamics of the couple and the relationship that is involved. So we cannot give an all-encompassing answer to say yes or no. That comes from the couple. But we do know that it is safe to get pregnant in the present time. And there are things that you can do to sort of help make sure that your pregnancy goes smoothly. The first thing is to always be in the best shape if you're trying to get pregnant. And also to take measures to avoid getting the infection. And we're talking about this normal safety precautions in terms of washing our hands, social isolation, staying safe from safe distance from others, and things like that. I would also advise that you get to see your doctor for your annual check if you haven't had one. And also to make sure that if you have any sort of chronic medical conditions, particularly we talked about high blood pressure and diabetes, then those need to be sort of optimized. The management, you need to make sure that they are well controlled before you get pregnant. We would recommend that you start taking folic acid, ideally from 3 months before conception, and also vitamin D is something that we would recommend in the population once you get pregnant. Again, I would emphasize that if you are thinking of getting pregnant, and particularly if you're high risk, it would be a good time to take the vaccine, especially because the vaccine has been proven to be largely safe in pregnant women. And also because if you're high risk, then you're more likely to get severe disease if you do get COVID. One of the things that is important to remember is that if you have young children at home, young children do not exhibit the sort of classic symptoms of COVID infection. They often have very mild symptoms, even when they're infected, and so can be transmitting the infection. So if you have young children, it's especially important to take precautions and to consider getting vaccinated if you are planning to get pregnant. Once pregnant, then you should register with your midwife or your GP, depending on which locality you're located at. They would then go ahead to arrange all the local tests and ultrasounds as per normal. However, there are things that may change in the times of COVID. So for example, some appointments may be virtual, but you still should get the appointments that you require. There may be limits in terms of who can accompany you to hospital, but I know that certainly in the UK, most hospitals make allowance for husbands and partners to accompany their wives, particularly for the really important appointments like ultrasound. Again, I cannot be overemphasizing this. It is important not to put off concerns due to fears of going to hospital if you have things that you're concerned about. Certainly, your emergency rooms are open 24/7. You may be able to get advice by phone, so you can call your midwife or your GP or the gynae emergency, obstetric emergency services on the phone for advice. Prof already touched on this, so I'm not going to belabor the point, but it's again just highlights the issues of who is at highest risk, and that just highlights our population again as being at particularly risk, especially those with comorbidities and also mothers that are older. Now, the symptoms of COVID-19 is already highlighted. Again, we know that the majority of patients will have no symptoms whatsoever. For those that get symptoms, the symptoms are often mild and are just like flu, cold symptoms. But if you're getting any of these symptoms, especially if you've been in contact or had potential exposure, then it's important to get in touch with the relevant services for testing to confirm if you have indeed acquired the infection. Now, one of the initial concerns at the beginning of the pandemic was the question of whether pregnant women, one, are more likely to get the infection, and two, whether if they get the infection is more severe in pregnancy. Now, what we do know is that pregnant women do not seem to get COVID more commonly than anybody else. However, when you compare pregnant women who get COVID and non-pregnant women who get COVID, those who are pregnant are more likely to get more sick, particularly in the last 3 months of the pregnancy. And the way we know about the severity of illness is that there's more admissions into intensive care, particularly, as I said, in the last 3 months of the pregnancy. Most pregnant women who get COVID will recover without needing to go into hospital or requiring any specific treatment. But again, you can get situations where there's a rapid deterioration or rapid worsening of the symptoms of the patient. And in those cases, it's critically important to go to hospital straight away. What are the kinds of effects of COVID-19? We've touched on some of this already. We know for a fact that patients with symptoms who have COVID-19 in pregnancy, there is a higher incidence of them delivering early, and that is 2 to 3 times higher. There's also an increased cesarean section rate in patients who have COVID-19, particularly those that were severe. And I think this was more common in the early days of COVID, where there was almost a doubling in incidence of cesarean section. Now, we also recently, more data coming out from the UK suggesting that women who tested positive for COVID-19 around the time of delivery were more likely to have a stillbirth. A stillbirth just means that you deliver your baby has unfortunately sort of passed away, died in the womb, and is delivered dead. So this is slightly more common in patients who have symptomatic severe COVID-19 in the latter stages of pregnancy. Thankfully, the actual numbers are very small. We know that, as Prof said, there is some debate about the risk, whether there's an increased risk of miscarriage. This is still a point of debate, but interestingly, I was just going through a recent study which looked at miscarriage that happened during the COVID era and looked at whether the patients had COVID-19 or not COVID-19, and there wasn't a predilection. So there weren't more patients with COVID-19 having miscarriages. In fact, it was pretty similar across the board. There hasn't been any increase in babies born with malformations as a consequence of COVID. And we haven't seen any evidence that babies in mothers who are COVID positive are small than mothers without. However, we did think that this is a possibility. So if a mother has COVID-19, the baby gets extra scans just as a precautionary measure. If a woman gets infected, can she pass the virus to the baby is another common question that is asked. Yes, infection is possible in the uterus, but thankfully is very uncommon. And again, when this does happen, most of the babies do not get very sick, which is a reassuring feature. It is also possible to pass the virus to the baby during childbirth and shortly after the baby is born. And so for those reasons, that's why we advise to take the safety precautions on the labor ward and if you have a newborn baby at home as well. What are your delivery options? The fact that you have COVID-19 shouldn't affect your options with regards to delivery. This should be determined largely by your history and your previous deliveries. So this will be something that your obstetrician and yourself will discuss. Cesarean section is not safer for women with COVID-19 just because of COVID-19. If you have to deliver in theater, then there's protection for yourself and for the staff in theater as well. And you'll be glad to know that you have all the options available for pain relief, whether you have COVID-19 or not. But as I did point out earlier, there may be restrictions in terms of who can visit or who can be with you on the labor ward. Again, another commonly asked question is whether you can breastfeed when you have COVID-19. And certainly we would recommend breastfeeding. It's the best for the baby. It enables babies to thrive. It builds a bond between mother and baby. But we advise safety precautions, washing your hands more regularly, using a mask when you're feeding the baby. And remember, never please put masks over babies because they can suffocate babies, and it's an absolute no-no. Now, Prof already touched on this. As you're aware, there's numerous vaccines that have been trialed, but typically pregnant women and breastfeeding women are excluded from trials. Now, what we have as evidence with regards to pregnancy is real life data from women from the US, where now over 100,000 pregnant women have received vaccinations with the mRNA vaccines. And those are the Pfizer, BioNTech, and the Moderna ones. And so far, there's not been any specific concerns raised. There's not been any increase in miscarriage, in abnormalities, in early delivery, in stillbirths, or babies dying shortly after delivery. There is also absolutely no evidence that any vaccines, including the COVID vaccines, cause fertility problem. And I think this is important to emphasize. And in fact, when you're having the COVID vaccine, you're not asked whether you're pregnant, or you're not expected to do a pregnancy test. And you can certainly go ahead and get pregnant straight afterwards if that's what you want. So as I said, recommended vaccination in pregnancy, particularly for those at high risk. But of course, the patient always has a choice in terms of whether they receive the vaccination or not after having the appropriate information. Our recommendation is certainly for you to take the vaccine, but that choice is personal. As Prof said, there's been rare cases of blood clotting that have been reported following the AstraZeneca and the Johnson & Johnson vaccine. Important to note that none of these were in pregnant women. And as also Prof has highlighted, so if a pregnant woman is being vaccinated, the Pfizer and Moderna vaccines are the first choice where they're available. But if you live in the part of the world where your options don't include those, then on the balance of risk, it's still way safer to get the vaccine, because your risk of clots is much lower from the vaccine than from COVID-19. And I'll show you some information in the next slide. So this is a really useful slide. One of the things that I would leave as a take-home message. If you look at the risk of blood clots with the AstraZeneca vaccine, 4 women in 1 million vaccinated women will have blood clots. If you take the birth control pill, it's 500 to 1,200. With the AstraZeneca vaccine, it's 4. With the birth control pill, it's up to 1,200. If you smoke, that goes up to 1,700. And if you have COVID infection, that goes up to 165,000 women per million cases. So there is absolutely no comparison between the two. It's thousands and thousands of times higher risk from COVID infection than from the AstraZeneca vaccine. That is useful information that we have to take into account, and of course, make personal decisions whether we need to take the vaccine. Prof already highlighted the fact that pregnancy in itself is a risk factor for developing blood clots, and the quoted figure is about 1 to 2 pregnant women for every 1,000 will get blood clots as a consequence of the fact that they are pregnant. So what have we covered so far? Should you be getting pregnant during the COVID-19 pandemic? Absolutely, if that's what you want. There are things that you can do to make sure that your pregnancy is safe and you have a healthy baby at the end. Once you get pregnant, you go see your doctor, and your care may be slightly variable from what happens normally, but it's critically important not to ignore any symptoms that you're concerned about because of COVID-19 and the fear of getting an infection in hospital. In terms of reducing risk, it's taking the safety precautions, getting vaccinated, watch out for the symptoms and report them and get tested. Delivery should not be impacted by COVID itself. Yes, you can breastfeed, and yes, we would recommend that you have the vaccine because it protects you, and there is some evidence that it also protects your baby. So I just added this so that you can get further information that is reliable. The Royal College of Obstetricians and Gynecologists website has lots of patient information there that you can access that is quite simple and available and ready for you to read. The CDC website, the Centers for Disease Control and Prevention, the WHO website, and of course, CamDocUK website, which you can access for talks like this, webinars, and also a lot of patient information for your use and for your families as well. So thank you very much for your attention, and we would be happy to take any questions.
Thank you very much, Dr. Nafti, Prof Konje, really amazing talks. I was just spellbound. So much information, and the feedback that we're getting is that there's lots of knowledge has been shared and gratefully received. May I please ask you to stop sharing your screen? There is a question that I just saw in the chat. I'm hoping she's going to put it in the question and answer box. If not, I'm going to come back to it. But if I go directly to one that came as you were talking about whether the vaccine affects fertility, and they just wanted to know how can you really be sure that that the COVID-19 vaccine does not affect women's fertility? It's not been around so for very long. How are we sure about that?
I think it's a valid question, and I'd like to thank the person for asking the question. COVID has been with us only for just over a year, and the vaccines have been with us for a much shorter period of time. So I think if we sort of said there isn't evidence now to say that COVID causes infertility. That's all we can say. Whether evidence will emerge 10, 15 years down the line, we don't know. But at the moment, all we can say is that we don't have any evidence. And there have been studies that have been undertaken in animals in the labs, where they found out there's really no impact on the structures that I talked about, the ovaries, the testes, the fallopian tubes, and the uterus. So you can infer from that. But I think it's always very difficult to take animal data into humans without following humans to see. There are a few women who have become pregnant having had the vaccination, but of course the vaccination has been around only for a short period of time. So it's very difficult to actually see whether what was found in animals is true in humans. But so far, we can say there isn't evidence to say it does affect fertility.
Yeah, and I think this is also true for other vaccines as well. So it's not just COVID-19. Our concerns usually with vaccines, it's more with regards to live vaccines and getting pregnant, because those can then impact on the development of the baby. There's absolutely no vaccines that I can remember off the top of my head that sort of cause problems with fertility per se, but it's more we're concerned about things like rubella vaccine, for example, having it and then getting pregnant, because that can affect the baby structurally and cause quite severe problems in the development of the baby.
Okay, so as we said that we're not really sure, but you know, if I've had a few patients say in their early 20s and they've asked me, should I just postpone getting pregnant for now and wait another 3 or 4 years because you can't really guarantee me anything? What would you say to that?
I mean, I think that's a difficult question to. There's no guarantees about anything, and I think the big question is really whether at that point in your life you want to start a family or not. Of course, there are consequences in terms of delaying pregnancy. I mean, your patient is only 20, so that's not so much of an issue as if they're 35, for example. But you know, at the present time, we don't have any data that suggests any sort of adverse effects from getting pregnant at the moment. Taking the necessary precautions to minimize risk, to optimize your health when you get pregnant, and also to sort of get vaccinated. Ideally, if you have time, then get vaccinated, protect yourself, then get pregnant. But even when we look at data from women who have gotten the vaccine at all stages of the pregnancy, there hasn't been any evidence of adverse impact on the pregnancies in terms of early deliveries, abnormal babies, or anything like that so far that we know.
Okay.
I mean, I think for your patient, the issue would be, should I take the vaccine? Because if I take the vaccine, could it potentially reduce my ability to become pregnant? Rather than, if I take the vaccine, will it affect the pregnancy? Because I think the evidence at the moment about the vaccine and pregnancy, there is a lot of evidence, at least for the Moderna and the Pfizer vaccines. So I will be saying that as a doctor who deals with high-risk pregnancies, it's actually safer having the vaccine than not having it, because you run the risk of dying from COVID. The risk of dying from COVID, you're pregnant, is doubled if you have severe disease than if you don't have COVID. And we know that COVID increases blood clots. We know that pregnancy itself increases blood clots. So you combine all of this, that increases the risk of dying even more. In fact, COVID actually increases the risk of you having a heart problem in pregnancy as well. So all of these things, I mean, we didn't talk about this because there's so much information. They make it much more risky to become pregnant and get COVID. And so vaccinating is better. However, if you're planning to become pregnant and you have a bit of uncertainty, a bit of anxiety that, look, I'm going to have the vaccine, but will it affect my ability to become pregnant? Maybe because we're in this area where we have some data that's not very strong. You may want to say, if you're younger, as Osric said, delay the pregnancy, but don't delay it for too long. Because I think that you will probably find out that it actually doesn't have a lot of impact. Looking at how the vaccine itself works, what I didn't go into is what exactly is the vaccines, what are they targeting? So that crown which I showed, the vaccines are targeting certain proteins on the virus itself. So they go into our body and they help develop antibodies against those proteins. And those proteins come from the virus rather than from the part of the body. So logic tells me that the vaccines are less likely to attack any part of the body that can cause fertility.
Wonderful. I think those are really sort of good points. When we have this chat, I think I said to her something along those lines, but I'll reiterate it the way you've just done. Thank you very much. There was actually a similar question about, I asked about women's fertility, and there's another question there for you, Prof, which said, how are we sure that COVID-19 really affects men's fertility? It's been around for just 1 year. So the same with the men's fertility.
Right. So that's an important question. And actually, currently we're writing some guidelines for Europe on COVID and reproduction. And there are very good studies that have emerged, especially from Italy, and I think some from Brazil, where they've looked at men who have had acute infection. And these men, they've taken sperms from them and examined the sperms. And the quality of the sperms has been poorer, much poorer. In fact, some of the men who had very severe disease had no sperms, what we call azoospermia. They had no sperms at all. Because the way that the human testis is designed, it's outside the body. So the temperature is lower than the temperature of the body. When you have very severe COVID infection, bearing in mind that the receptors, what I spoke about, receptors are also in the testis, the virus also targets the testis, causes an infection there, the testis becomes very hot, and if it's very severe, it kills the cells within the testis that eventually produce sperm. So this data is actually suggesting that if men have very severe disease, a significant number of them go on to have fertility problems. That is not something that is, it's controversial. The data is there.
Thank you, Prof. Just a reminder to our audience, we have launched a poll We'll be grateful if you could complete it for us. It will help us to frame our future webinars, make sure that we've done a good job for you today. Just to say that we have some questions for our other speaker, Dr. Amy, but she'll answer those in the next few minutes. There's another question there for you, Prof or Dr. Nafti. It says, good evening all. Is there a relationship between COVID-19 vaccine and a reduction in blood and iron in the body?
No, I am not aware of that. What we know is that there is something, and I'm going to use a medical terminology here. It's to do with the cells in the blood that affect blood clotting. So it's called vaccine-induced thrombocytopenia. And that is linked to the Johnson & Johnson and AstraZeneca vaccines. These are thought to be what causes the blood clots, but there's no linkage that I'm aware of between vaccines and anemia. I'm not aware of that at all.
Okay, and there is a question there for you, Dr. Nafti, about breastfeeding. I've had my mRNA COVID shots and I'm currently breastfeeding. Fortunately, I never contracted the virus, but will my baby get some protection from COVID via breast milk as they do with some vaccines?
Good question. Yes, there is some evidence that that's the case. So one of the reasons for recommending the vaccine is the potential benefit. So once the mother gets the vaccine, she produces antibodies, which we know cross the placenta. And so this can provide protection for the baby. Yes, so it's one of the reasons why we're currently recommending that. Yeah.
It's a very, very good question. In fact, some data that was just published from the United States in JAMA 2 weeks ago, they looked at babies that were born to mothers who had vaccination in pregnancy, and they checked the antibodies in the cord of the babies, and there were significant levels. So that will offer protection for the baby for the first few months of the delivery. Yeah, so breastfeeding actually does exactly
helps.
that. Yeah.
Wonderful. So a really good idea then to get your COVID vaccine, because if you're not only protecting yourself, when you do breastfeed your baby, you're going to be protecting your baby as well.
Yeah.
That's
in
really
addition to all the safety precautions.
Yeah.
Yes. They've also another question about mRNA vaccines while we're on them. Is there a possibility for them to be teratogenous?
No, so so for teratogenicity, for those who are not medical, are things that cause malformations in babies. And I think Dr. Nafti was very clear. The safety data from, because that's where we have the largest safety data from the United States, where they've now gone and looked at over 100,000 women, and most of the problems that things that cause malformations in the babies tend to happen very early when the baby is being formed. And these women had a vaccination, some before they became pregnant, and some very early in pregnancy without knowing. And up till today, there is nothing to suggest that the mRNA vaccine will increase the risk of babies having malformations.
That's really good to know. There's another question here. I think, Prof, you mentioned about fibroids being one of your favorite things to talk about. Anonymous attendee, I was scheduled for a myomectomy 2 weeks ago, but while in the theater, ended up with a myomectomy, a right ovarian cystectomy, and adhesiolysis. All went well, but 2 weeks later, I am still suffering from gas in my stomach, which causes so much pain before it comes out. How can I deal with that? This is my second myomectomy with a C-section between the two. What can I do to ensure it doesn't come again? Oh dear, that's a very tough question.
Right, so is Dr. Amy around? Because I don't want to steal some.
Dr. Amy is currently off camera. Dr. Amy.
I'm here. Sorry, I've just had a technical glitch with my camera. I'm quite happy for you to steal my thunder.
Okay, I think the first thing that I'd just like to say, I'm really pleased that you're able to have surgery and have adhesions divided. So these are things that get stuck together. So you had them freed as part of the surgery. I hope those were discussions that you had before the surgery, because you having had a myomectomy before, having had a cesarean section, the risk of things sticking together is great. Now, the more surgeries you have, the slower it takes for you to recover from surgery. That is for sure. So you've had 2 myomectomies, you've had a cesarean section, and so things will be much, much slower. Your bowels take much longer to recover. The risk of things sticking together are much greater. So in terms of the gas that you have, all that we can recommend is look at your diet. There are certain things that you can, I'm always recommending that patients take things like peppermint water because it helps to get rid of the gas in the abdomen. And it's just a question of time, and things will get better. I mean, there's really nothing magical about it.
Thank you, Prof. I hope that answers your question. We launched a poll about to ask our attendees whether they found that their knowledge has been improved by listening to you, and 39 people responded, and 41 people responded, and 39 as a resounding yes, to say that they have more understanding about the topics that we've spoken about today. So, which is really a testament to your talk. So thank you so much. We'll go to some more questions because there are more on there. The next, we'll give one to Dr. Amy, if you can answer this. So this is a controversial one. Dr. Amy, does using a hair relaxer make you at risk of having fibroids? What about vitamin D deficiency? Does that also increase your risk?
Thank you. Yes, those are quite difficult questions because I don't think there's any clear evidence out there at the moment. I know that there was a lot of talk after a study was published a while ago suggesting that Black women who used more hair relaxer and used it at a younger age were more likely to start periods early and also more likely to get fibroids and have more fibroids. But I don't think since then there's been any further evidence that this has been proven. So I think the short answer is I don't know. Is it possible? Probably, or maybe, but there's no evidence at the moment to suggest that. I think the fact that women who don't use hair relaxers also have them, and women who are not Black also have them, might suggest that the hair relaxers are not the cause of the fibroids.
Well, I can just we can all breathe a sigh of relief. What about the vitamin D deficiency? Any link with that? I found that question quite hard myself. I really hadn't heard much about any studies about that as well.
No, I certainly haven't heard or read any studies that clearly prove that vitamin D increases your risk, or vitamin D deficiency increases your risk of fibroids, unless Professor is aware of something.
No, I am not. I don't think there is strong evidence. I mean, I'm very careful the way I phrase this because I don't want to say there isn't any evidence. I'm not aware of any evidence that says vitamin D increases the risk of deficiency, increases the risk of fibroids. But I just want to comment on the hair relaxer to say, look, I trained in Nigeria, and I know that Professor Jaiyesimi is on one of the attendees, and Dr. Vincent Bamigbo is also one of the attendees who've worked in Nigeria. Well, I worked in Nigeria in the late 80s where hair relaxers and stretchers were not very common. And I can tell you that fibroids were extremely common, even in women who were having many, many children. So I do not believe that there is a link between the hair relaxers and fibroids. But I do know that fibroids have a genetic link. There's a very, very strong genetic link. Because if you take families that have fibroids, you see that it runs in families. And there are many other factors that I think may be precipitating people to developing fibroids rather than the thing that the hair relaxers.
Thank you for that, Prof. I was just scrolling down the questions. There's a few questions on there. Same person, I think, about the anemia. So just asking, please, how can you explain that after having your second vaccination, so I'm presuming they had their second vaccination, they had nearly all the side effects. They went to A&E, they did a blood test, and they said you had a little blood clot and your hemoglobin and iron levels were low. I don't think I understand the question very well, but Prof, did you understand that? I can read it again.
So if I understand you properly, so they had a second vaccine, they had side effects, went to the emergency, and they found out that their iron level was low. And they might have looked at the bloods, the cells in the blood that deal with blood clotting, and then they found out those was probably low. I'm just trying to figure out. That's
yes,
the
I think that's the best way to kind of explain the question. Yes.
And I mean, if they had the Johnson & Johnson or the AstraZeneca vaccine, that the low platelet levels is one of those very rare things that has been reported. That's what I talked about, vaccine-induced thrombocytopenia. That's been reported. It's very, very rare. Now, if that suddenly happens, what often happens is actually that the people would have blood clots in very, very unusual places. But there have been reported cases where, I'm aware of cases where people have actually had periods, and the periods have been slightly heavier because of the drop in the blood and in the platelets. So whether that happened in her, I don't know. But these are very, very rare things that have been reported.
And the other point to make is that in those reported cases where you had problems post the vaccinations tended to be with the first dose. Now, this is someone who I presume has had the same vaccine, dose, and this is their second dose. So it's difficult to sort of understand, because typically the side effects and those, particularly the blood clots, have been reported with first doses. Although I suppose it's possible still to happen after the second dose.
But also, I'm sorry to come in again. Also, we don't know what the situation with this individual was before she went to the hospital.
Yes.
It's possible that you might have something that is pre-existing, and then because of the reaction to the vaccine, you go to the hospital, and it's very easy to start linking the two. So without knowing where the starting point was, it's very difficult to actually say this is linked to the vaccine.
Correct.
Exactly. And so, Gogo, if you can just, I think that was the name of the person who put the question in. If you can just give us a bit more information, what vaccine did you have? Did you have the same one? If you can remember what terms were given to you, because sometimes it's very difficult for us to give you a good answer to your question when we don't have all the facts. But I hope the answers we've given you there have been helpful. So there's loads of questions on here. Let's have a look at Cosmas. Cosmas has asked, has there been any baby born with COVID? If so, are there any short-term or long-term effects on the baby?
Right, I'll let.
So there have been babies born with COVID or who have acquired COVID shortly after delivery.
Should I say the virus rather than
the virus? Sorry, and it tends to be very mild. So there's been. You remember in the slide I said the question is, can my baby get the virus? Yes, your baby can get the virus in utero or at the time of delivery. Thankfully, it's uncommon, and when they do get affected, it's very, very mild in the babies.
So they just to add, I'm afraid that I'm going to come in and say the evidence for a baby acquiring the virus in pregnancy is suspect. So, I mean, we've written a paper which has been coming out next month on COVID in pregnancy, and we looked at the data a lot. And the 2 cases that I know that have been reported saying the baby has been born and they picked up the virus and the baby, they've been questioned a lot by international experts, and the methodology has been questioned. But what we know is that babies have been born with a type of antibody that you can only develop if you have an infection. And so they've inferred from those studies that if the baby has developed the antibodies before being born, because you cannot develop those antibodies unless you've had the infection for at least 3 to 5 days. So if at birth you have those antibodies, it means you've had an infection in the womb. But they couldn't identify viruses in these babies. So up till now, there's been no reported effect of the virus on the babies, even in those that have been putatively acquired the virus before being born.
And in some cases where we've done what you call amniocentesis for whatever reason, which is taking some of the amniotic fluid from around the baby, in some cases there's been the virus identified in the amniotic fluid. So that would increase the likelihood that it would transfer to the baby. But again, we looked at it and we tried to publish it, as Prof said, and there wasn't any sort of convincing clear evidence with regards to this.
Okay, thank you. Very helpful. I'm aware that it's now 7:43. We were planning to end at 7:30. We did start at 6:10. I think there's some appetite there's more questions on there. I think if we can continue.
Happy to continue.
Yes, okay. Perfect. Prof Jaiyesimi has actually made a very nice point in the chat there, and actually I was wondering if we could let him speak and just make his point, because I think it would be really helpful. Prof, if you're happy to do that. Anna, can you allow Prof to speak either, and then he can be.
I've done that.
Perfect, thank you. Hello, Prof, sorry to.
That's all right. Good evening, everybody, and thank you for putting up this webinar. Justin, nice to see you. What I put in there has to do with our collagen. Now, we as Black people have more keloids than Caucasians. And we don't know why. Is it genetic? Is it something to do with our collagen? And could this be related to fibroids as well? There's no research that I know about it. And we as Black scientists cannot wait for Caucasians to undertake the research for us. So my suggestion is that we should do it ourselves. So the fact, as Justin will know, Igbora, where there's the high twinning rate and people were talking of FSH and estrogen, I do not think that fibroids were said to be common in Igbora than other parts of Nigeria. So it's very complex. There's no direct proven link between hair relaxants and fibroids. Thank you for the opportunity, and thank you to all the speakers.
Thank you so much, Prof. Thank you for allowing me to put you in the deep end. Thank you. Right, there are some more questions on the question and answer bit. Ornella on YouTube asked about whether the COVID impact, whether it wasn't too soon to affirm that the COVID vaccine has no impact on fertility and pregnancy. Ornella, I hope you heard that question being answered. We have some people watching us on YouTube. Perfect. A question for you, Prof. Would you recommend that patients known to have thrombocytopenia, so low platelets, choose to have the Pfizer vaccine rather than the AstraZeneca in view of the potential risk, though very rare, of thrombocytopenia associated with AstraZeneca?
What a superb question. Really, really very good question. And I just like to thank the person who's asked the question. The answer is yes, I will. And we actually do recommend that if you have a, you know, I think most of the governments that were trying to advocate COVID vaccine passports were talking about people who may not be suitable for COVID vaccines. I think that if you had thrombocytopenia, you have any risks that, not just thrombocytopenia, but you have any risk factor that increases the risk of you having blood clots, for example. Some we call thrombophilias, for example, or somebody in your family who's had a blood clot and we don't know why they had a blood clot and you haven't been investigated because there are certain risk factors inside an individual that increases the risk of that person having blood clots. I would say there has to be some caution in taking vaccines. And if you're going to take the vaccine, I would strongly recommend that you talk to an expert, maybe a physician who is involved in the vaccines. And I'm sure that they'll be pushing you in the direction of the mRNA, which is the Pfizer and Moderna vaccines, rather than the AstraZeneca and Johnson & Johnson. And there are a certain group of people that none of the vaccines will be suitable. And we know that. I can't start talking about the certain groups of people here, but there are certain people that will be unsuitable. In that case, they just have to follow the precautions that Osric spoke about to prevent acquiring the infection. Yeah.
Thank you very much for that, Prof. Amy, Dr. Amy, a question for you. Is there a role for homeopathy in the management of fibroids?
Thank you. It's a very interesting question. I think there have been a couple of studies that have looked at women taking. Yeah, I think there've been a couple of papers that have been published looking at women who've taken homeopathic remedies for fibroids, and they have suggested that the women found some benefit. However, these studies have not always met what we classify as the thresholds for good evidence. So they've not been incorporated into routine practice. Personally, what I would say is if you were going to use anything that was helpful and not harmful or dangerous, and it helped, then I don't see why that would be a particular problem. But I'm not certain of strong evidence to suggest that homeopathy can help certainly get rid of fibroids. Yeah.
Thank you for that, Amy. And just one more on there for you that I saw. I think actually the question was wanted to know about how one can manage fibroids, which I think your whole talk was about, but maybe just they came in a bit late. So just one or two sentences about that for her benefit.
Absolutely. Probably should have ended with a summary slide, but basically fibroids are common. The way they occur in every woman is completely different. So some will have one, some will have multiple, some will have tiny ones, some will have very big ones, some will have small ones. Having fibroids doesn't mean that you're going to have problems. In fact, most women with fibroids don't have problems, so you don't have to do anything about them if you don't have problems. But if you do have problems, what the management's really geared towards managing those problems. And it's very different depending on the problem you have. Common ones are bleeding, and management for bleeding is really targeted at managing the blood loss and the pain, maybe giving you some hormones, whether it's in tablets or in implants or coils to manage that, or doing operations to shrink or remove the fibroids, or there is medication that can shrink the fibroids, but you really need to have these conversations with your doctor to figure out the one treatment option or the treatment options that are best for you. If you have other problems, for example, pressure problems, then you really want to think about taking the fibroid away. You can manage your day-to-day life in other ways, but if you want to get rid of the pressure, then you really want to get rid of the fibroid, especially if it's a big one. So there are different ways of doing that. A lot of them are operations, and the ultimate one really is taking out the womb, because that's the source of the fibroids. If it affects fertility, then again, that's really a conversation you should be having with your doctor and the fertility specialist. Some fibroids need to be removed to help improve fertility, but sometimes it's about looking at other ways of having a baby. If it affects you during pregnancy, then it really depends on the problem, and management's targeted at what the problem is. I hope that kind of covers it.
That did. Thank you for that really excellent summary. So I hope that that was okay for you, Agogo. So the final question, which is all to do with, there's about 3 questions that are around the same thing. So first one was, I had COVID and wondering if it will affect my sperm production. Can I get someone pregnant? Following back on what was said about fertility with the sperm, how do we know that there was no issue with the person's sperm before they had COVID? I think that kind of summarizes the last 3 questions on there about fertility.
Okay. You've been unmuted me.
Yeah.
Okay, just before I answer the questions, I think I'd just like to really thank Amy for really an amazing job on fibroids. I just want to say something about fibroids, and particularly for those who, wherever they're listening. My experience with fibroids is that, and I'm sure Professor Jaiyesimi will actually agree with me, that experience with doctors who deal with fibroids varies very widely. A lot of the people in the UK, and I'm really sorry, a lot of our colleagues who are trained in the UK, who are clinicians in the UK, have never had the real experience of dealing with multiple huge fibroids. And if you have fibroids in the UK and you're going to seek medical advice, try and find out how good the person you're going to see is. I saw lots and lots of patients who had come to me with fibroids, and they have been given advice that is conflicting and confusing. If you find the right person, you'll get the right advice, as Dr. Amy has clearly outlined in her very, very nice presentation. Now back to the question on COVID and sperm count. I'll take the second one first, which is to say that the studies that I made reference to, they were looking at sperm counts in men who had fathered children, who presumably had normal sperm counts before they had the COVID. And that evidence is there. Well, of course, you can say, well, you fathered 3, 4 children, and then 6 months later, you have COVID and have a problem. You could have had a problem with your testes before you had a COVID test. That is possible. But when you look at a significant number of people, so that is highly unlikely. Now, you've had COVID. Will it affect your ability to have children? Well, I will say here that it depends on how severe the COVID was, whether you had, because this data that I'm talking about are data of patients who were very, very sick, were admitted in an intensive care unit, and were ventilated. Now, if you had very, very severe COVID and that you needed ventilation, I would say there's a slight possibility that it could affect your fertility. Now, what we don't know is how long that impact on fertility would be. Is it 6 months, is it 7 months, is it 3 months? Will the function return to a level that is good enough? My feeling is that most people who have mild to what we call mild to moderate COVID, that it doesn't have any impact at all on their fertility.
Thank you, Prof. It's been really amazing. It's now 7:56. We still have most of all of those that were here from the beginning. Really, thank you, guys, for really, really engaging. So many wonderful questions. You know, a lot of people have learned a lot. Just to say that this is being recorded, as you can see already. It's live on YouTube. Within a few sort of hours, even less than that, it will be available on YouTube, and it can be watched again. And I'm sure a lot of us will be doing that. This will be on our website as well, CamDocUK.org. But really, I can't finish without actually showing you some of the backroom my colleagues that have been helping me. So I'll start with Dr. Morgan, who is, she may not be able to turn the camera on, but Dr. Morgan is the previous chairperson. I took over from her, and she was just saying before that actually the 3 previous chairpersons of CamDoc are all on one webinar, which is the first time that has happened. Dr. Morgan has taken her time today. She's actually been working all weekend and has really answered, been engaging with you guys, as you can see on the chat. So really thank you very much, Dr. Morgan. Dr. Bene, who actually, she's not allowed to go on holiday because she's the only one who can get these webinars on. Dr. Bene, please show us your lovely face. She's done all the surveys. She makes sure that, everything runs really smoothly. Everything is recording. So we wouldn't be able to do any of this without her. And she is our communication secretary. She's also our financial secretary. So I don't actually know how she finds the time to do everything. So thank you so much, Dr. Bene. Dr. Ngwa, who is our educational secretary, he is the one that has come up with all the topics that we're talking about. He has been really amazing since we began these webinars. I wonder, Dr. Ngwa, do you just want to tell us about our next webinar, please?
Yes, sure. Thank you. Our next webinar will be on the 17th of July, and the topic will be exercise and health in the era of COVID-19. So we're going to have another set of brilliant speakers on that day as well. Thank you. Thank you so much,
Dr. Ngwa. We also have Dr. Dimala, Christian Dimala. He's in audio. I think he's all the way from America. This is our webmaster who, despite having moved country, he's always there. He does if you've seen our posters, all the posters he does them very efficiently, always with a smile on his face. He may have had to disconnect. He just did a night shift, but Christian, thank you very much. And I must end by just thanking our speakers again today. It was really amazing. It was so brilliant. I learned a lot from all of your presentations. You were all so clear. Also, it was really good. I'm usually a stickler for time, but I couldn't stop at the 7:30. There was just so much useful pearls of information. Thank you so much for all offering your time. And we hope to see you again in July. And the talk promises to be really amazing. Thank you for giving up your Saturday to come and speak to us, to come and listen to us. The recording will be available on YouTube. Please watch it again. I know I'll be watching it again myself. There were lots and lots of useful questions from you all. So without further ado, I hope I haven't forgotten anyone. Thank you so much. And